All right, good afternoon, everyone. Thank you so much for joining us today. Very excited to bring some subject matter experts to give you an overview of the agreement between Nevada and the Department of Justice that was going to result in children's behavioral health system transformation. Just a little housekeeping as we get going. As you may have heard, this webinar is being recorded. I've been able to get the recordings available on YouTube. There's the link. I can also pop that in the chat for you as well. And we will also make it available to all of our partners for embedding at a later date. As I get the slide deck, I will make sure that it is posted on nvbh.org. That is the website for all 5 of the regional behavioral health policy boards. Please keep your microphone on mute unless you're called upon. You should all be automatically muted, but if for some reason that gets jumbled up and you don't realize you're on mute and there's some sort of feedback, I do reserve the right to go ahead and mute you. Please enter your name, title, and agency in the chat if you haven't already done so. And let's go ahead and hold questions for the end of the presentation. At that time, you can either use the raise hand function, which will be on your toolbar, or there's also a Q&A box. If you don't see any of those options on your toolbar, there should be a round circle with 3 dots in the middle that say more, and you can find those there. This webinar series was brought to you as a collaborative project by the Nevada Public Health Association's Policy and Advocacy Committee, the Behavioral Health Association of Nevada that was just launched at the end of last year, and all 5 of the regional behavioral health policy boards. The purpose of this webinar series was to help our attendees get a current snapshot of what's going on with behavioral health systems across Nevada as we move into the legislative session. Obviously, this is the end of week 2, so we're already into the session. That's why we wanted to have this one be the last one and end on an important note so that we can kind of move forward and start looking at other things as well. We've made all efforts to include speakers who are both subject matter experts, but also who don't stand to gain politically or financially by participation. A little bit about the regional behavioral health policy boards. There are currently 5 boards, each representing a region. The boards consist of 7 to 13 volunteer members, and they represent both their local and professional perspectives. So the board seats range from everything from law enforcement, criminal justice system. There's 2 or 3 different types of behavioral health providers that are required, a peer family member, etc. The purpose of the boards is really to advise state level agencies and commissions, particularly the the Division of Public and Behavioral Health, as well as the Commission on Behavioral Health. Each board is allowed 1 bill draft request, or BDR, each legislative session. And as we look at the regions here, we have the Washoe region, which is there in pink. It's just Washoe County. The northern region, which is the western rural counties. In blue, you see the region that I serve, which is the rural region. In green is the southern frontier, southern central frontier and rural counties. And then last but not least is Clark, which includes Clark County and the southern tip of Nye, so that it also includes Pahrump. Each of the regions is staffed unofficially by a regional behavioral health coordinator. These are my counterparts. You've got Dorothy Edwards based out of Reno for the Washoe Regional Behavioral Health Policy Board. Sherilyn Rar-Woods is the coordinator for the Northern Regional Behavioral Health Policy Board. Mark Funkhauser is our coordinator for the Southern Board. Myself there in blue. And the Clark position is currently open, but if you need contacts for that board, please let me know and I will try to get those for you. All right, so with that being said, I'm going to go ahead and stop my share and I'm going to turn it over to Ann Jensen. Thank you, Ann, so much.
Thank you, Valerie. I am sharing my screen now. Let me know if you're able to see my slides.
Yes.
Wonderful. All right. Well, hello, everyone. Happy Friday afternoon and Valentine's Day. It's nice to meet you all. My name is Ann Jensen, and I am the Innovation Officer and Agency Manager at Nevada Medicaid. And I have the pleasure of working with a number of folks across our state to really lead our children's behavioral health transformation. At a high level, this effort has been underway for almost a year now within our Medicaid program, and I'm really thrilled to share a little bit more about what we've been doing and our path ahead. I'm also really excited to be joined by our partners at the Department of Justice, who we've been working very closely with regarding a settlement agreement on these very initiatives that aligns quite well with the transformation efforts that we've already been undergoing. So we're going to spend some time today really talking about both the transformation and the details of the settlement agreement and how that overlaps to the work that we have planned for us in the years ahead. There's a lot of ways that we're looking forward to working with each of you and in your roles across the state, and we look forward to your input throughout this process, and we'll be sharing a little bit more about what those stakeholder efforts will look like as well. So quick summary of where we're headed this morning or this afternoon. We'll share a summary on the transformation timeline, a little bit about the settlement agreement, and then I'll turn it over to our Department of Justice colleagues to share a little bit more about themselves and their role in this effort. And then I'll take us through a few details regarding how to read the settlement and what areas of focus we have off the bat as a state team, and areas where we look forward to your input as well. So with that, I'm excited to share just a very high-level vision for our work. While I think this is perhaps the most 10,000-foot view of what we're doing, it's important to ground us in why we're doing the work and who we're here to serve. And that really is youth across the entirety of our state and every community that deserve access to behavioral health services to support them in thriving within their families and their communities, to stay at home and in their communities. So everything we're doing is in line with that vision. What is best for our youth? What is best for their families? And how can we best support them as a state? And so those values that are guiding us include, it is child-centered, family-focused, really based on community and what our unique communities' needs are. While this is a statewide initiative, we know that it's going to look vastly different in Clark County and Washoe and across each and every one of our rural counties. And so we're trying to really learn best from our community to develop a model that works in each of those areas. Accountability is crucial to all of this. While Medicaid is the leading agency for the path towards compliance with this agreement, we cannot do this alone, and we are working very closely with our state and community, our county partners in particular, to effectuate many of the areas of policy that we do not control. And so that joint accountability across our full state is really crucial to this work. And that requires a coordinated response. So I'm really looking forward to sharing a little bit more about systems we're setting up to do that, and look forward to your input on how best we can incorporate particularly the work of our policy boards and your input in this process throughout the years ahead. So that's the vision. This is a very busy slide, but really is meant to show where have we gone and where are we headed, right? So there's three main questions that summarize this work. The first is, what benefits are available? Benefits is the term that we use in Medicaid language to describe what services can we reimburse providers for that they're giving for youth or families in our community. The second question is, what is the delivery system? What does it mean? Who is paying for these benefits? Who is paying the providers? And what does that insurance card look like for our youth and our families to access them? And then lastly, what is the front door? How do our youth access these services? So at the highest level, again, April 2024 was a really important step in this work in which the Nevada legislature approved about $20 million of funding to begin these efforts. This is actually thanks to legislation that was passed last session that allocates a portion of our provider assessment program revenue towards children's behavioral health initiatives. So there is a really robust and sustainable funding stream for this effort. We anticipate around $200 million of funding in just the next biennium alone, which is a really unique opportunity that we have as a state to utilize that funding stream. So we're really appreciative and got started with that work in April. Since then, we've been assembling a team, myself and an army of folks behind me to support this work. And we've gotten started with our first new benefits and rates changes that went live effective January 1st. The settlement effective date was just the day after on January 2nd. And so that's what we'll be spending a lot of time on today. But the settlement includes a number of benefits that we'll need to be developing as a Medicaid agency, and I'll speak about that shortly. But we anticipate by January 1st, 2026, we will have requested approval for all of those from the federal government. And those will be accessed by youth and families across our state as soon as they're available for that reimbursement. The big date, though, is January 1st, 2027, which sounds far away and I know is not. We are hard at work to move towards a really transformative effort, which will look like a single specialty managed care plan that will provide the full array of both medical and behavioral health benefits for youth that are eligible. It will include a really robust care management continuum with levels of intensity varying on youth and family needs, and will include a really robust and comprehensive screening and assessment system to ensure that we're really identifying what are our youth's needs and how can we best support them to really be as preventative and proactive as possible in providing this support. So 1/1/27, the green box on the right is that big date. Happy to speak to any details when we pause for questions at the end, but I did want to give a quick snapshot of what this looks like over the years ahead. So what does stakeholder engagement look like through this, right? So you'll see our regional boards have a yellow box around them here on the bottom left. There are so many important forums where this work is being discussed and has been being discussed in some cases for decades. I know our Clark County Consortia was established in the early 2000s, so this work is not new to anyone in the state, I know. And so we're trying to be very thoughtful about not just creating more forums, but utilizing our existing ones appropriately and developing very unique chances for folks to provide input on Medicaid benefit development. So that's what you'll see at the top. Our working group, which I'll share more about, is really intended to provide a lot of input from youth, families, and providers, as well as other community partners on exactly how we're creating the system from the Medicaid standpoint. We know we have a really unique opportunity with a lot of momentum and resourcing to do it, but cannot build anything that doesn't work for our youth and families. And so that working group is really intended to provide that input throughout the course of all the years you saw to come on that slide. So a little bit more about that working group. Over the summer and fall, we recruited for folks to join. We got nearly 200 applications for 29 selected seats. I will not go through each of these bullets, but you'll see we tried to be really intentional about bringing a diverse group of folks to the table here. So we have people from across our state geographically. We have folks from every type of behavioral health provider that will be involved in this system. We have family representatives that include experience both as biologic and foster parents to really ensure that we're representing the full range of experience as best we can of families across our state. I'm really excited and thankful for our youth representatives as well that are providing input based on their lived experience with our systems too. So I will also call out, we have representatives from many of our consortia and regional behavioral health policy boards included in that forum. So you may see some familiar names and faces in that group, but they are open to the public and we would be thrilled for any and all to join. We've had, I think, nearly 200 people on each of these, and it's been a good chance both for representatives to provide input, but also for members of the public to share more about their perspectives as well. So I'll share at the end the date of our next meeting and what that will look like, but just wanted to start with who are we talking to and what does that look like? And I'm really grateful for the opportunity to be here with our boards because I know you have a lot of really important expertise and insights to lend to this effort. So thank you to Valerie and team for including us in this webinar series. So with that, I'm really excited to share, as I mentioned, the settlement agreement that we're discussing was signed effective January 2nd, 2025. The full agreement can be found publicly online, and I'd be really grateful if one of our DOJ partners is willing to drop that link in the chat, as I know you all don't have access to the hyperlink in the slides yet. But I would love to turn it over to them to share a little bit more about their work and kind of context for what is reflecting many years of effort to get to this point. So Haley and team, I'll turn it over to you.
Thanks, Anne. Hey, everybody, I'm Beth. I am one of the DOJ attorneys that has really had the pleasure of working with Nevada for a while now. And we've been lucky to be able to meet some of you and your colleagues and really are so grateful to be here and are pleased to be a part of the settlement agreement that we'll now be working with Nevada to implement. As many of you know, this dates back to an investigation from a couple of years ago. And that was an investigation that could only happen with the input of folks throughout the state, including kids and families and providers. And when we say throughout the state, we really mean it. And I am particularly aware of what it means to be hearing about this from the perspective of folks who live in the rural counties. So we're definitely interested in continuing to collaborate with the state on what it means to deliver services effectively to kids who live in the rural counties. So we're super glad to be here. Anne is going to talk through a little bit of what the settlement agreement contains. But throughout, we are happy to answer questions about our role or about anything in the agreement. So before I turn it back to Anne, I just wanted to introduce and make sure you all note the other folks on my team. Haley Van Arum is another attorney on our team, and Dana Bridgewater is here as well. She is an investigator on our team. We have, it has taken a lot of work to get to this point, but it will take even more work going forward. And we are committed to continuing to be involved and to be present in Nevada physically sometimes, but over email and phone and text and all Zoom, all electronic formats as well as we move forward. So yeah, we're really excited about the partnership.
Thank you, Beth. I appreciate it. And I'm really glad and thankful for your partnership and all the effort it took to get to this point. I joined the state in July and feel like I just joined the very end of a lot of hard work. And to your point, now we're on to the next phase of really exciting and important work to do. So really thankful to be doing it with you all. And as Beth shared, feel free to drop any questions for the team in the chat. We'll also save time for questions at the end as well. So to get into a little bit more of the settlement agreement purpose and goals here, you'll see this is pulled directly from the text. So if you're interested in reviewing in more depth, we encourage you to do so. But as Beth shared, the purpose is really to ensure that we're preventing children from being removed from their family home to obtain the treatment that they need and deserve for their behavioral health conditions. And so the focus and goals are really to develop our home and community-based system of care to allow a more robust array of offerings to help our youth be able to stay and not have to access residential care unless it's clinically indicated and the right time and place to do so. So at the highest level, really focused on those home and community-based services, as that we view as the missing link in Nevada's existing behavioral health continuum. And I know that's putting words to things that everyone on this call has felt and seen over and over throughout their careers or lived experience in the state. So wanted to really bring it back to what that means and what's driving us to do this work. In terms of how to read the settlement, I think it's helpful. I called out a few sections that are maybe most useful for this group. Section 2 really focuses on the definitions of services. And I think it's really crucial to think about. We say home and community-based services. What does that actually mean, right? What does that look like in terms of as a youth or family member in our system? What types of things can you expect to be available as this becomes live over the years to come? Section 7 calls out our behavioral health policy boards actually explicitly. So if you want to look for a shout out, you can find that there in Section 7. But at a high level, it's a really important document for all of us to be aware of, and I encourage folks to take a look. As it's listed there, the state's path to compliance with each and every item in this agreement will be audited by an independent reviewer team. So we're excited to have them coming on board very shortly. And again, this is a 5-year term for the state to achieve compliance with each of these items here. However, we know it will take more than 5 years to really develop the provider infrastructure and landscape of this work. We are playing the long game here. This is a marathon. And so I'm really thankful to be doing it alongside a lot of really talented people that have a lot of expertise in everything that we're doing in the state. So with that, I think one important question to answer is what population is the settlement agreement focused on, right? Who is eligible for these services and how are we focused on this? So the blue box shows the legal definition of the focused population. The summary at the left really goes to show it's focused on Medicaid eligible youth, which right now is 1 in 2 kids across our state. And it's focused on those kids with the highest level of need for behavioral health services. And so all settlement terms apply to this population in particular, with the exception of both screening and assessment, right? We want to be able to screen as many youth as possible to ensure that we're supporting them as upstream and as early in their care journey as possible. And of course, our mobile crisis response and stabilization efforts, we want to ensure are available to all youth across the state, regardless of what insurance payer they have or what other diagnoses or conditions they have. That service will be available to all. So that's a settlement agreement focused population. I do think it's important for us to call out that's actually a little bit of a smaller bubble than how we're viewing our transformation population overall. So our goal is not only to ensure that every youth in the focused population has access to the care they need, but also to try to get a little bit more upstream to identify where are youth struggling or could benefit from more care. They may not have gotten a formal diagnosis or a determination of serious emotional disturbance, but how could we better support that youth and their family right now to prevent them from ever getting there? And so what we're doing is trying to really define that transformation eligibility, meaning who's eligible for that specialty managed care plan and services, even broader than the focus population. So at right is a few areas that we're exploring. That eligibility is not written in stone yet. It is not final. We're actually going to be taking that to the working group for input in the months ahead. So we'd love your feedback on whether we're really capturing all possible youth that could benefit from these services within our Medicaid population. And importantly, number one includes the term at risk, which is a pretty challenging term to use, right? It's quite vague. And so we're going to be working with our working group to identify who are those youth and how best can we use our data and the data that we have to ensure that they're eligible for the services that they need. Again, and other important categories include youth with co-occurring behavioral health needs and intellectual or developmental disabilities. We recognize this population of youth has a very unique combination of needs, and we want to make sure that our system is designed very uniquely to best serve and support them. So we're working closely with our partners at the Aging and Disability Services to do so. And I look forward to input here as well. We're also looking very closely with our colleagues at the Division of Child and Family Services, as well as our Washoe and Clark Family Service partners, to best find ways to serve all youth in our state foster care system throughout this initiative. So I'll keep moving. Really share a little bit more. As I mentioned, some of those acronyms and our state partners are really called out here on this slide. So, well, again, like I said, while Medicaid is the kind of leading agency on this effort overall, we are doing this in lockstep with our partners across the full Department of Health and Human Services, as well as our Office of the Attorney General. The administrators of each of those divisions are meeting on a bi-monthly basis to review our path towards compliance with the settlement agreement, and are working very closely to tackle some really complex issues that span each of our agencies. One good example is mobile crisis response, right? There's at least 4 agencies that are involved in that work right now. And so we've created a sister agency support team that's focused on the program leads for mobile crisis in particular. And they're meeting to really work through the details of what does our current system look like? How do each of us play a role in achieving compliance with the settlement agreement? And have brought some really important areas of feedback to their leadership and administrators in that forum. You'll see the green row is exactly where this group and many others live, which is that stakeholder input section. That is crucial, as we shared, for all of this work. And the orange box at the bottom is the folks that the army of people behind me that are supporting this work. I'm really deeply grateful for all that they've taught me and are continuing to push forward. There are folks across every team at our Medicaid agency that are supporting this work, and I'm really grateful for them for everything they've done up to this point and will continue to do. Another important question, and this may be a familiar slide for folks that have joined presentations that Administrator Weeks has given on our behavioral health services in the past, but it's really an attempt to answer, how does a settlement agreement align with the reality of our behavioral health care continuum? So one way that we've tried to summarize what is an incredibly complex system of care is these 4 buckets, ranging from low intensity to high intensity. And you'll see for each of these buckets, there's sections of the settlement agreement that speak directly to competencies or areas that the state needs to strengthen our support. And so you can read exactly what those details look like in the settlement. But again, I think it's helpful to kind of contextualize every aspect of our behavioral health system is impacted by our work here. And we're trying to increase the size of these bubbles and maybe more proportionately invest in others, but each and every one is impacted by this work. At the high level, here's a summary of some of those home and community services that we are developing or have already developed. Home services are on the left, and you'll see most of these are actually going to be new for Medicaid to be reimbursing for, although we know they're not new in terms of the folks in the state providing these services. Those include wraparound care coordination, planned and emergency respite for caregivers, family and youth peer support, and then the ones at the bottom, individual and family therapy and psychosocial rehab services. Those are really crucial. Medicaid has been reimbursing for them, but we recognize there was opportunity to really analyze how we reimburse and align that with medical inflation rates and national best practices. So I'm excited to share there will be some details on a rate reform that we've undergone internally with a very different reimbursement model for some of these coming out in early March. So on the right, our community services. So again, things that are available at various locations in a youth's community. We know that our schools are really crucial partners in this effort. They should not be the sole behavioral health provider for any youth because they have many other things on their plate already, but they really do play a unique role in identifying and supporting our youth and families. So some of these services will be kind of accessed first through that school forum for some youth. Others will just include outpatient providers or other community partners that will be facilitating these really important services. Almost all of these are services that we are actually just looking to enhance or improve in terms of our Medicaid kind of coverage. Those are not net new services for the state. Those home services are a bit of the newer ones. So I know this is a lot of information that I'm moving through quickly. So again, welcome questions or feedback at any point. Residential treatment, as Beth shared, is a really crucial part of the settlement agreement. We want to ensure that that treatment continues to exist in a high quality manner in our state for the youth that need it. And so we've already made some efforts to change our policy and reimbursement structure effective January 1st of this year, really to align with current federal regulations and better define what does it mean to provide residential care. We're also recognizing that youth with complex needs require different types of service in the setting. And so we're allowing for additional services to be billed separately, for example, ABA services. And we developed a new reimbursement model that essentially compensates providers at a higher rate if they demonstrate that the youth that they're serving will require additional staffing or resourcing to best serve. So youth that are under 9 or have other sort of complexities in their care needs, we want to ensure they have appropriate access to this really important service. This is a little bit moving away from the benefits piece to how do we actually access those benefits? How do we deliver these benefits? And so blue box again is a settlement language. What does it mean is on the left, which is we are required to utilize a new delivery system to deliver benefits to eligible youth. So the delivery system means we have two flavors of this in the state right now. One is fee-for-service delivery, in which the state is directly providing that payment to providers. The other flavor is managed care, in which that payment flows through an organization that manages the care of the population that they're serving. And so it's a little bit, the state is compensating those managed care organizations who are then contracting directly with our providers. And so national best practices in other states have been to create a special managed care plan that's only for the youth that qualify for these benefits. And that will allow for an array of offerings that are different than what we have in either fee-for-service or managed care right now, and really helps to kind of streamline the way that youth are accessing the care and the benefits that they need. It will be very different than what our current managed care models look like. We're designing it uniquely to this population, and it will have a lot of care coordination requirements in particular that will feel quite different. And so we're learning from our national partners that have implemented this successfully in other states, but also we need to find a way to do this right for the state of Nevada. And so calling out that stakeholder input will be really crucial as we design this program. We'll be going through those efforts throughout the coming spring and summer in preparation for a procurement process that will begin this winter. And so really look forward to feedback from this group, and we'll be sharing more details on what those opportunities to provide feedback will look like. So moving forward here, what does it look like now that we know what's in the settlement agreement? What does it look like to actually achieve compliance with this? And so we really anticipate that this will be a full 5-year process. There's a lot of work that we've done, and there is a lot of work to continue to do. And we know that to consistently achieve compliance requires availability of providers and access points throughout the state that are going to take some time to develop. So you'll see kind of the orange, yellow, green motif continued throughout slides. I'm going to run pretty quickly through what's coming up ahead. So again, invite folks to add questions to the chat, but I do want to share kind of how the state is viewing our path to compliance across each section of the agreement and who we're working with at Medicaid to be able to achieve that compliance. So the first section we'll touch on is screening and assessment. The goal of this is to really develop a statewide system of assessment to ensure all Medicaid eligible youth receive the screening and referral where it's clinically indicated. This touches nearly every sister agency and partner across our state because we all use different flavors of assessment tools right now. And so we're spending a lot of time figuring out how can we best take things, not add something new to our providers' plates, but in fact, take off anything that is maybe duplicative and instead have a single consistent model moving forward. This is going to be a long process. We know it takes a lot of time to change our workflows, and we want to do it the right way with a lot of input from our providers in particular. So we anticipate that this will be a significant effort that we'll start bringing to our working group as early as this spring. Section 4 is really focused on service planning and coordination. So how do we create care coordination for our youth to help them kind of navigate what is an incredibly complex system, both of medical and behavioral health benefits, but also all other systems they're involved in, with their schools or corrections agencies or foster care systems. And so we're working with a national expert vendor to really help inform how can we think about care coordination as a continuum best in our state, given what we currently have and what our sister agency partners are already doing. So a lot more effort to come and a lot more details to come on this front, but that's going to be really crucial, particularly for that specialty managed care plan. Section 5 is about those home and community-based services. So the benefits that we're developing to ensure that we as Medicaid are paying for these services that we know will really support our youth to stay at home and in their communities. So as I shared, our first batch of enhancements was submitted to the federal government for their approval effective January 1st. So we're hopeful we'll receive that approval this spring. The other benefits are ongoing throughout this year, and we anticipate submitting all of those by the year end. So a lot more to come on that front. We're bringing each of those benefits to our working group for their feedback throughout this year. So we definitely welcome you to join and provide detail and your input there. Diversion and transition is the name of Section 6. What this really means is residential treatment. How do we ensure that youth are receiving high quality care for just as long as they need and no longer? And so, like I shared, we've already done a lot of work in this front, but it's going to require a lot of monitoring and continued tweaking to ensure that the way that we are developing our systems is aligned with our overall goals. So again, that work is ongoing. You'll see February 2025 is the working group discussion. That was actually supposed to be last night, but due to the snow, we will be having that conversation in March, and we welcome any folks to join and provide their input on how we're designing what we're calling a quality incentive program, but really trying to tie our payment to residential treatment facilities to the outcomes of the youth that they're serving. Section 7 is stakeholder engagement. Again, this is not something that we are viewing as a checkbox exercise by any means. This is foundational to every step of this process and every section of our work. While it's green at the bottom, it's only green if we continue to do it. And so I'm really appreciative of our team that's been working really hard and creatively about how can we best bring folks into this work? How can we be as transparent as possible in what we're doing? And how can we spread the word as far and wide as we can? So this is a great example of one way to do it. And I'd welcome feedback from this group. If there's communities that you're part of that could benefit from a summary of our work or would like to provide input on a particular area, please don't hesitate to reach out to myself directly or to our team. I will drop the link to our website here in the chat, and I'll make sure Valerie has an access to that for her to share with the follow-up materials, but you can always get a hold of us there. We'd love to really continue to get your input throughout this process, and we appreciate the time that you're taking to do so. So with that, we have one more section, which is workforce and provider development. This is foundational to all of this work, right? We can develop the benefits so Medicaid is allowed to pay for it. We can create a plan for folks to enroll. But if we don't have providers delivering the benefits, that doesn't change anything for our youth and families, right? So really thinking with our partners across the state to figure out how can we attract new providers to our state? How can we best train our existing providers to serve these youth with complex needs? And how can we do so in a really creative manner, knowing that this is a constraint that Nevada is dealing with across all types of providers, across all types of services. So really looking forward to more work and would love any creative ideas you all have on that in particular. Section 9, I lied, we did have one more, is really an important one because it's about quality assurance and performance improvement. How do we know that the changes we're making are actually tied to the outcomes that we want to see? So we have a robust team that's conducting population health analysis, and we'll be sharing a lot of that reporting and dashboards publicly. However, this will be an ongoing effort, and we're excited for that to be shared again on our website and through our various community engagement platforms, so you all can take a look at the results of these efforts and provide your input on that as well. So with that, I know I've shared a lot of information in a short amount of time, so I want to thank you. I'm really grateful to be here and excited to be part of this really important webinar series at the beginning of session. Again, we welcome you to join our next working group meeting, which will be Thursday, March 13th, where we'll be discussing our psychiatric residential treatment facilities. And again, details on all this work, you can sign up for our email listserv, you can watch recordings of our previous working group meetings. All of that can be found on our website, which is on this slide, but I will also drop in the chat as well. But with that, I will stop sharing and Valerie will open up for questions.
Wow, thank you so much, Anne. That was incredibly helpful. I really appreciate it. So if you have any questions for Anne or anyone on the DOJ team, please feel free to either drop it in the Q&A box or use the raise hand feature in the toolbar as well. While we're waiting for folks to formulate their questions, I do have a couple. So you mentioned emergency respite. Is that for family or for kids? And if it is for kids, would that be more like a crisis stabilization unit?
That's a great question. I'm happy to take a stab at it and then welcome any folks from the DOJ team to speak to how they've defined it in the settlement as well. So planned and emergency respite is really geared as a benefit for caregivers to allow them a break, either a planned break or a time when they didn't anticipate needing it, but to best support them and ensure that youth can remain long-term in their care. So it takes kind of a different flavor in every state, and we want to make sure we're building it in a way that would allow for that full range of flavors. So I don't want to speak to what exactly that will look like because we know there's quite a range of models. But I will say, to your point, it will be different than crisis stabilization. Emergency respite does not if a youth is in a moment of crisis, a crisis stabilization center is the appropriate place for their care, and a mobile crisis response is another avenue we'd love to offer in that situation. Emergency respite is more about the caregiver is really in need of some very short-term relief and support, and it's more on that caregiver definition front. But Beth and team, anything you'd want to add to that?
I did just want to add that there is a definition of respite care in the settlement agreement. It's definition number U or letter U. And it says that it is short-term care for a child in the focus population by natural supports or formal providers designed to offer temporary relief, can be planned in advance or offered in emergencies or times of crisis to the family of a child. It may be provided in the child's home or in other homes or home-like settings. So I say that just to point out that if you click the link that we put in the chat, there are some definitions and parameters that can also be helpful in understanding some of this stuff.
Fantastic. Thank you, Beth, and thank you, Anne. All right, looks like people are still working on their questions. So another thing that popped into mind was, do you have any idea yet regarding how many providers would be needed to meet this need? And are there any particular provider types that should be focused on? I'm asking this as you're likely aware that the Rural Regional Behavioral Health Policy Board, as well as many others, are really highly focused on workforce and bolstering our workforce. So any thoughts on that, even just preliminary ideas?
I know that saying everything is not really a very helpful answer, but I do think that there is going to be need across the full spectrum. I would call out in particular for the new Medicaid reimbursable benefits. So youth and family peer support, respite care, wraparound services. We anticipate even more need for provider infrastructure development and new providers, existing providers in the state, because we haven't offered that as a reimbursable benefit before. And typically that means that our private insurance partners haven't been as well. And so that means that these providers haven't received a sustainable resourcing like funding stream from payers in the past, which often leads to not very many payers in the state. So I'd say those areas are particular focus, but we need high quality, well-trained providers serving youth in every aspect of this delivery system. And so I'd hate to limit it to anyone in particular. And I'm really appreciative of the policy board's efforts and bill draft requests as well related to this area. I think that aligns very well with the settlement agreement.
Awesome. And then what type of providers are allowed to provide that emergency respite? Is that something that is done by like a marriage and family therapist or an LCSW, or what are kind of the things going on there?
Yeah, it's a good question. That's actually what we're still working to figure out based on both national best practices, clinical best practices, and how our other Medicaid partners have developed it. So as Beth said, the settlement agreement definition is foundational for all of this, but then we need to figure out how do we translate that to Medicaid policy? And so that's exactly the types of questions that we'll be kind of grappling with and bringing to the working group in the months ahead. So no decision on that yet, and would love your input if you have particular ideas of how we could best think about crafting that.
Fantastic. Thank you. And then are there any particular existing resources when you're talking about youth services? Things that spring to my mind are things like the teen text line, which has seen a a lot of use. Are there things like that in Nevada that are assets that we can just kind of be aware of to make sure that they're in place by the time that we're able to build up the system so that it can use it?
A great question. I think a couple that come to mind for me initially, I have three that come to mind for me off the bat. One is 211, right? What other kind of human services offerings are available? We encourage folks to connect there. I know the teen text line is kind of a subset of that, but that would be an important resource. 988, our crisis response line, is really going to be crucial throughout the course of this work, and I'm really excited that we have that right now. And then the last piece, which I think is maybe a little bit less well known, is the Connect NV program, which is run by Magellan. They're actually providing these really comprehensive benefits such as wraparound, respite, and peer support to eligible youth right now. It's available in most of our rural counties as well as Clark County, and that will be expanding to Washoe hopefully very soon. And so that is available on the Connect NV website. You can get connected with our screening and intake team there. But they are really supporting us both in learning how can we deploy these benefits best in Nevada, but also we know there's immediate need, and that 5-year timeline means nothing for a youth in crisis right now. And so it's one attempt that we're making to try to better support our youth in this kind of bridge time period. So that would be the last resource that I'd call out as well, and welcome others to add anything in the chat that I may be missing.
Thank you so much. That's incredibly helpful. I was actually, for some reason, not aware of Connect NV. So I will make sure to try to get the message out about that. All right, so last call for questions from our attendees. Please feel free to again use the raise hand feature, or you can drop your question in the Q&A box by using the button in your toolbar. Going once, going twice. All right. Well, thank you, everyone. I really appreciate your time and expertise. This was fantastic. Again, I'm going to be getting this video up hopefully by the end of today up on YouTube. And I will hopefully get to stay in touch with you. I'm so excited about this. This sounds like amazing stuff that every community needs. So thank you again. And I hope you all have a great day.
Thank you, Valerie, for the chance to be here. We appreciate it. Yeah, and have a lovely weekend, everyone.
Bye.
Thanks, everyone.